Okay, good evening, everyone. Today we'll be completing the remaining regional anesthesia equipments. Last week we finished on central neuraxial blockade. Today we will cover the peripheral nerve. Okay, so coming to the basics of you have LOR, regional peripheral nerve blockade will include your landmark guided blockade blocks using the LOR techniques. So these are based on distinct pops. Okay, so all facial plane blocks are with some distinct pops felt. That is the landmark guided blocks or laws of resistance techniques. It relies on blunt or short beveled needle, which provide good feedback. That is stereotactic sensation. You should feel the pop or click when it passes through the various fascia. Following blocks can be given with the LOR technique. These are sure short FICB, that is fascia iliaca compartment block, the tap blocks, the rectus sheath blocks, the ilioinguinal, iliohypogastric blocks, the superficial cervical blocks, and many other blocks. Okay, that is the PEX 1 and 2, the serratus anterior plane blocks, the erector spiny plane blocks, and even thoracic paravertebral plane blocks can be given with using these landmark guided or laws of resistance technique. So we have to understand that we have to blunt the needles. How do we blunt the needles? The concept of cushion effect and feeling of the pops and clicks through them. And basically, above and all, you should know the surgical anatomy very well. The laws of resistance needles, these are the commercially available short bevel needles you can have with an extension tubing, or you get those blunt pencil point needles also nowadays, uh, which provide good tactile feel of the LOR, that is the pop, when they pass through the fascia, come with the extension tubing, which makes it easy to handle and prevent displacement while injecting. The needles available in the OT, which you can use for these techniques, are the epidural or the Tui's needle, the blunt drawing of needles, these are available now, the bullet or the pencil point spinal needles, or you can blunt an hypodermic needle too. How do you blunt a hypodermic needle? They are sharp and can be used for LOR technique after blunting them. The methods of blunting is scrape it against the inner walls, the inner vertical striations of the uh, ampule cover, the needle cover itself. You can rub the needle with the sharp point on that, or you can blunt it by grazing it on the ampule, inside of the ampule, sterile, okay? Or you can just take a single tap on a sterile trolley or a bowl or whatever you're using for your antisepsis. Okay, so this then you make it like a parrot beak. You blunt it either inwards or outwards. That doesn't matter. Now you can also use two um needles, one of a bigger diameter, and within needle, through needle, you can use it to bend. So the LOR needle should be the smaller one in this case. Okay, so you bend the needle, not so much so that it doesn't go through the skin at all. Now what happens is, by blunting the needle, you need lot of force, require more force to pierce the skin. It obliterates the cushion of the underlying subcutaneous fat. So what happens is, just like this, how when you're lying on a cushion, it gets bent, dipped inside. Similar way, when you are using a blunt needle, you get the skin and the subcute fat gets so much depressed that it overshoots, okay, and you miss the LOR plane or the pop feeling and you go ahead, overshoot the plane. So this is called the cushion effect. So when the skin is breached, the needle passes through the skin, subcute and the fascia. Okay, and when you go far deep and then you feel the pop in the deeper planes and the drug gets deposited in the deeper planes. So how do you prevent the cushion effects? By making small nick in the skin with a surgical blade or a bigger needle. An 18 gauge needle has a sharper edges. You can use that to make a nick in the skin, or you can use a needle through needle where the LOR needle is passed through the large sharper needle. Okay, so the sharp introducer needle, you go beyond the skin, and the pencil point or the blunt needle is passed inside through the sharp needle to get into the right plane. Or what you do is you withdraw the needle back upwards after the initial insertion, okay, in up and then you withdraw it up to the skin and then go feeling your pop or the LOR. Okay, now before feeling the LOR, first feel the bounce on the fascia and then the pop. That is the key points. Initially insert the needle at 30 degrees till it pierces skin and subcute, and then change the angle to 90 degrees. Okay, then LOR blocks provide relief only from somatic pain, and multimodal analgesia should be given to all the patients. And these are volume blocks, so more volume is required, and one can decrease the concentration to increase the volume. And success depends on the knowledge of surgical anatomy, cushion effect, and its prevention. Okay. Now, coming to the peripheral nerve stimulator, the basic principle is that a small amount of current is applied to the nerve via the needle and connected to this peripheral nerve stimulator machine, and the nerve is stimulated, and which contracts the muscle which it innervates, which contracts to give the end motor response. So the peripheral nerve stimulator first was described by Luigi Galvani in 1780. He described the electrical neuromuscular stimulation in a frog. In 1912, Perthes brought in the first PNS machine. Now, to understand this, you have to understand the electrophysiology and the neurophysiology so that we can use the PNS better. The nerve cell has a resting membrane potential of minus 70 millivolts. Okay, means that the inside of the cell is more negative as compared to the outside by 70 millivolts. Any decrease in this potential from minus 70 MV will result in a depolarization, and after a certain threshold, the action potential is ensued. Okay, hence, when we attach the cathode, that is the negative polarity of the PNS machine, to the needle or the nerve locator, so that the negative polarity can decrease the current or the potential difference more effectively across the membrane to give us more effective nerve stimulation. Okay, so that is the cause for the depolarization, which leads to action potential generation, and it propagates along the nerve to stimulate the muscle, giving us the end motor response, and that is the contraction. Okay, to be able to give good nerve stimulus, we have to achieve good charge in the threshold, which is equal to the product of the current intensity and the pulse duration. Okay, so the total charge threshold, that is Q, is equal to the current intensity MA into T, that is a pulse duration MS. Okay, that means a sufficient current has to be given for a sufficient duration of time in order to get the desired action potential. That is quantified in terms of the Rio base that and chronaxine. Okay, so the every nerve has different chronaxine. and reobase. So the reobase